Hola, buenas tardes a todos. Hola, buenas tardes a todos. Vamos a darle la bienvenida a la doctora Alexandra Freeman y a todos nuestros juniors conectados. Para no aunar más en el tiempo, la doctora Freeman es graduada de la Escuela de Medicina de Georgetown. Es graduada con honores. Ella fue residente de pediatría del Hospital de Niños de New Haven en Yale. Y su formación también tiene una especialidad en infectología pediátrica en el Hospital Memorial de Niños de la Universidad de Northwestern en Chicago. Ella actualmente es directora de la Clínica de Inmunodeficiencias Primarias en el NIH en Estados Unidos, y la línea de investigación que ella dirige sobre inmunodeficiencias primarias, donde también está la historia natural y la patogénesis de lo que son los síndromes de hiper IgE, así como la linfopenia idiopática CD4. La doctora es experta y ampliamente renombrada con este espectro de errores innatos de la inmunidad. Actualmente tiene más de 200 artículos sobre esta línea de investigación, varios capítulos del libro, y es profesora pues a nivel internacional y reconocida. Es un honor para mí presentarla y que comparta con la Sociedad Latinoamericana de Inmunodeficiencias Primarias y sobre todo con los juniors que nos encontramos el día de hoy sobre este tema que ha sido pues en gran expertise por parte de la doctora Freeman. Bienvenida, doctora.
Thank you so much. I really appreciate the offer to speak today. Let me see. Oh, I can't share my screen yet, but then I can share my slides if that's possible.
Yes, you can share now, doctor. Thank you.
Okay. It says host disabled, participant screen sharing.
Oh, please try again.
Now it's doing. Now it's letting me. Excellent. Okay, thank you so much again for the kind introduction, and I'm happy to be speaking today. I've never actually been to a LACID meeting. I was going to go many years ago, and then the federal government had to shut down because of our politicians not agreeing on budgets, and they didn't let me travel because the government was closed. So one day I hope to make it to a meeting. Anyways, I thought today I would talk some about the hyper IgE syndromes. Here's a picture of NIH. This is the hospital building. I'm right up here in this building right now, talking to you all from my office. And this is where we see pediatrics down here on the first floor and our adult patients up here. So when we refer to the hyper IgE syndromes, we're really referring to the triad of having a high IgE, eczema, and recurrent lung and skin infections. And since STAT3 was identified as the gene causing autosomal dominant hyper IgE syndrome, or the most common cause of that, otherwise called Job syndrome, back in 2007, there's been multiple genetic etiologies identified that can lead to a clinical triad like this. And each of them is really unique and has different kind of aspects to it. For instance, with the Job syndrome that I'll talk most about today from the dominant negative STAT3 mutations, they have connective tissue abnormalities and remodeling abnormalities, but other of these genetic defects have worse allergies or eczema or viral skin infections like DOCK8 deficiency. DOCK8 deficiency is actually now a combined immune deficiency, but I'm leaving it here because these are the diseases I see most days. Anyways, we study these at NIH because our hope is through studying these rare monogenic diseases that we can really then understand, for instance, how does a mutation STAT3 cause things like atopy or the host control of Staph aureus infections, or things like warts for DOCK8 deficiency or vascular abnormalities for STAT3. So the hope is to really then broaden this to a bigger population. So today I was going to talk, probably mostly about STAT3 dominant negative mutations or Job syndrome, but I'll talk a little bit about DOCK8 deficiency and IL-6ST as well. So I'm going to start first with the STAT3 ones, or otherwise referred to as Job syndrome. So this was initially identified in the 1960s, 1966, and two girls that were not related who lived in Washington State area, and they were being admitted with recurrent pneumonias and boils and eczema. And they actually named it Job syndrome from the quote from the Bible about Job being smote with boils. So there is Job there with boils coming down on him. A few years later, IgE was identified, and then Becky Buckley, who's at Duke, put together hyper IgE recurrent infection syndrome. And then the genetic etiology was discovered many years later in 2007. So I'll talk first a little bit about the clinical presentations, and then talk a little bit about the immunologic findings, a little bit about our research, and then some about management as well. So the presentations usually right in the newborn period with a rash. So the babies, might even be born with a rash or within the first couple of weeks have a rash. And this is a typical baby. This baby was born to a mother that had the known diagnosis of Job syndrome. So she was diagnosed earlier in life. And you can see kind of the crusting around her ears. This happens a little earlier than typically eczema would present in an infant. But the eczema in this disease is usually not very severe, and it's usually driven by Staph aureus colonization or infection. So typically, if you put the patients on something to suppress Staph aureus, usually some sort of combination of antibiotics and antiseptics such as dilute bleach baths or chlorhexidine washes, usually, it's not as significant as some of the other hyper IgE syndrome. And often in adults, they really don't have eczema at all. Individuals then often develop recurrent boils starting early in life, and this is caused by Staph aureus. And, these are referred to frequently as being cold, in that they don't often have a lot of the systemic signs of inflammation. So they're not usually that painful or red or hot, but if you put a needle in these, then they really are full of neutrophils. So it's more, it's not really that the neutrophils don't know where to go. It's more that the usual signs of kind of infection are a little bit muted, probably because of some impairments in the IL-1 and IL-6 signaling. And same thing with pneumonias. So usually early in life, the individuals start having trouble with pneumonias, bacterial pneumonias. Staph aureus is number one, but they can also have strep pneumo, Haemophilus influenza early on. And again, they might not have those usual signs of infection. So the patients might not have a fever, their white count might not be high, their CRP might not be high, so it can be really tricky to diagnose. And I like to tell the story of this patient in this CT here. This was a known patient of ours with Job syndrome, who was in her early 30s when she had this pneumonia. And she had actually contacted me and said, that she was pretty sure she had pneumonia. So she had gone and gotten a chest CT over her lunch break from work, and she had FedExed it to me. She lived down in Florida. And so I opened it up, the next day, and this was her pneumonia. And, I called her up, and she said she was busy at work, and, she was really okay. But, I reinforced and made her come up to get seen that day with us. And this was actually a pure MRSA pneumonia. So it was a methicillin-resistant Staph aureus pneumonia. So, any of the rest of us that are immune competent that had this severe a pneumonia would be really quite sick. But it's really remarkable how these patients cannot look all that sick from this. And then you can see here with the pneumonia, a lot of the destruction of the lung parenchyma. And I'll talk about that later. But, then there's healing issues, and they're left with pneumatoceles and other changes. And then the patients often have mucocutaneous candidiasis. They can have fingernails with thrush, and they can have, fingernails with yeast and thrush, vaginal yeast infections too. This disease is really unique because of so many other abnormalities. So the patients have very flexible joints, and as they get older, they have a lot of trouble with joint arthritis. They have scoliosis. About 3/4 of the patients have scoliosis, and it can be so severe that it can impair their pulmonary function, and they might need rods to be placed because of that. And they break their bones more easily. They have minimal trauma fractures. They usually have some degree of craniosynostosis. So, their skull shape is a little bit different, and there can be a downward displacement of the cerebellar tonsils that can be a Chiari malformation. If you look at the brain MRIs, there's often these little focal spots of hyperintensity. This is we think are related to small vessel disease. You can see these in otherwise healthy individuals as they get older, like, in their 70s, 80s, often associated with hypertension. But we see this even sometimes in the children and young adults. Their baby teeth don't fall out. Most of the patients had to have most of their baby teeth pulled out. And then we see middle-sized arterial aneurysm. Here is a patient that had a large aneurysm that had a clot form inside, leading to a myocardial infarction. There is a characteristic facial appearance. This often emerges through later childhood and adolescence. It's kind of a larger, fleshy looking nose, some facial asymmetry, kind of a jutting out chin. The patients, you know, sometimes will look more like each other than their siblings, and they can actually often pick each other out in a waiting room, for instance, at our clinic. By the way, this is my oldest patient right now. He is 71 years old now. So we were really confused when I joined the group. So I joined the group here at NIH in 2005, working with Steve Holland. And at the time, we're like, okay, genetically, you know, we didn't know what was causing this. And, you know, how are you going to be able to connect the teeth with the, you know, the skin infections and the pneumonias and the bone issues? So in 2007, that connection was made with dominant negative mutations in STAT3. So this was reported initially by the group in Japan and then by our group here at NIH. So I just was lucky that I just joined the group at that time. So just to go through a little bit about what the STAT proteins do. So, you know, that stands for, well, the STAT protein, signal transduction, activation, and transcription. So then there's, you know, there's STAT 1, 2, 3, 4, 5, 6, and some of those have, like, for instance, STAT 5, A and B. So these are dominant negative mutations in STAT3. So this is heterozygous and is passed down in an autosomal dominant manner. And about a third of our patients are actually spontaneous. So it's the first diagnosis in the family. Oopsie. But, you know, a lot of cytokines signal through STAT3. So here are some of them, and they're both pro-inflammatory cytokines like IL-6 and anti-inflammatory cytokines like IL-10. Here's one, IL-11, that's involved in things like teeth and bones. IL-17 that we'll talk more about. Anyways, the cytokines bind to the receptor. JAK gets phosphorylated, STAT3 then gets phosphorylated, it dimerizes, goes into the nucleus, and leads to gene transcription. So again, it's the signal transduction, right, which happens right here, then activation and transcription down here. And it makes sense that STAT3 would have such varied clinical presentations, because STAT3 is expressed by all, you know, everything in the body, and it's involved in tons of pathways, with the immune system, cancer, wound healing, vascular remodeling, you know, so it is really, truly a multi-system disease that we see for its issues in the immune system. So shortly after we found that STAT3 mutations cause Job syndrome, we put together that one of the most consistent immunologic findings in this disease is a lack of Th17 cells. So, you know, around that time, Th17 cells were being identified in mice as being involved in epithelial immunity and with their role in terms of Candida epithelial immunity. And we knew that STAT3 was one of the transcription factors that led to the T cells to differentiate to Th17 cells. So it seemed like a good likely target here. And if you look at the patients, these are the ones with STAT3 mutations. These are healthy controls. And these turned out to be mostly patients with DOCK8 deficiency back then in 2008, before we knew about DOCK8. But you can see they really don't have Th17 cell differentiation here. And it kind of makes sense that the main immune issue in this disease is epithelial immunity, because they get staph infections, but they get staph infections of the skin, they get staph infections of their lungs. So, but they don't get what you see, for instance, in chronic granulomatous disease, or they don't get very often, where you get like a staph liver abscess or a staph osteomyelitis. We see those things sometimes, but not like you do in CGD, where it's a neutrophil problem that goes to a neutrophil issue in CGD, and that leads to then the you know, more visceral abscesses that you see with Staph aureus. Here it's epithelial immunity, so you see it more in epithelial areas. So you see their infections like causing thrush, and you cause skin infections, and you cause pneumonias. You also see some of the endemic fungi in this disease in the GI tract. You can get really significant histoplasma infections that can look like almost like Crohn's disease. You know, anywhere we've seen it from the tongue all the way through the rectum. Cryptococcus we've seen cause esophagitis as well as CNS cryptococcal disease. And then we've seen coccidioides cause CNS disease. And, you know, you have coccidioides and paracoccidioides in Latin America, so that might be a concern as well. And in this country, you know, any of the patients that are in our kind of Southwest area where they have cocci, I make sure that they're on prophylaxis, just because it can be so severe with the meningitis and the brain infection. There's other immunologic findings we see as well. We see less memory T cells and less memory B cells. I like to think with the less memory T cells, it's most apparent because we see these patients getting shingles more frequently. So here is a baby with Job syndrome that was diagnosed early because her father had the disease. And here she is with chickenpox. And she actually had a quite mild case of chickenpox because this isn't like a primary T cell issue. But, here is a 9-year-old boy with shingles. So we don't see trouble initially with the virus, but we do see reactivation more frequently. And then it's not very severe, and then they're good again for a while. But, we do see shingles in about a third of our patients. And because it's not severe, we do not do prophylaxis for these patients, though. And then the B cell defect, again, there's less memory B cells. So that can lead to, not as good specific antibody production over time. And with that, some of these patients end up on immune globulin replacement. One thing that's interesting about this disease is that they tend to be kind of allergic people, but not allergic like you might imagine with a really, really high serum IgE. So we noticed this over the years because the patients were often told that they had lots of allergies because they had, for instance, blood IgE testing against a bunch of foods, and they were all positive because there's a lot of non-specific IgE, but they were actually usually eating those type of foods. So it got very confusing. So we actually did a more in-depth history of that. In fact, that when you look at the patients with a STAT3 mutation compared to others with similarly high IgEs, that, they actually have a lot less food allergies. And if you look at anaphylaxis, it's a lot less. So when I get a referral who doesn't have, who's never had genetic studies, if the patient sounds like they're having anaphylaxis to lots of things and with a really, really high IgE, I often think it's not going to actually be a STAT3 mutation. Then we did some research actually back then collaborating with Josh Milner to try to understand why, was this a problem with the IgE or was this a problem with the mast cell? And to see whether or not, is a trouble with the mast cell, we actually did morphine skin testing because morphine directly causes degranulation of the mast cells. And you can see here that the patients with a STAT3 mutation, more of them did not react to morphine. So it really seems like those mast cells are less twitchy in this disease, and that is probably relates to STAT3's activity in the mitochondria as well. But everything else about this disease has been extremely hard to figure out because STAT3 is just expressed very widely. It's involved in many pathways, so when you try to understand, well, why don't the teeth fall out? We really don't get that. And I still don't have an answer about that. But, we started thinking about this more when we figured out that these patients have middle-sized arterial aneurysm, some of the non-immunologic issues. So this patient, just to tell the clinical story, he was a patient with known Job syndrome who was followed at NIH for many, many years. And he had high blood pressure and was a smoker and had high cholesterol. And he presented when he was 43 years old with a large MI. He was actually found pulseless. But luckily for him, he was on a road and his car went off the side of the road and there was someone with a defibrillator like driving right behind him like a policeman. So he got defibrillated and somehow amazingly survived this incident. Went to his local hospital and was transferred down to NIH. And so you can see here on the heart catheterization, here is his left anterior descending artery and it has this big aneurysm and a clot had formed inside that. And, another thing that was interesting was despite him having a lot of atherosclerosis risk factors, he had 0 calcifications and no sign of atherosclerosis. He had a smaller aneurysm right here in the diagonal branch and his right coronary artery was enlarged as well. So at the time, we didn't know, is this a coincidence or not, but then shortly after we saw him, another patient came in who was older than him, about 10 years older. And when we were getting the history on that patient, he had actually had a heart catheterization because he had chest pain, but it turned out to be related to esophagitis. So we got that heart catheterization report and he had almost identical aneurysms, except it was just a little bit smaller. So this one's aneurysms were 9 millimeters in diameter and that one was 7 millimeters. So at that point, we decided this must not be a coincidence. So going back to this patient, 10 years later, he had a life-threatening GI bleed from a mesenteric artery aneurysm. And then more recently, he's had really severe spine disease leading to surgery for his neck, his cervical spine. And then actually in the past year, I diagnosed him with lung cancer and he had that resected and is doing well. I'm actually seeing him next week. He's now 60 years old. But this made us study really the middle-sized arteries in this disease. And We routinely screen the patients for coronary artery aneurysms by MRI now, and we also look at their brain arteries for any cerebral artery aneurysms because there have been a couple cases of Berry aneurysms or other middle-sized arterial brain aneurysms that have led to fatal bleeds. Here's an example of that. So, and what we found is that, it's pretty common in these patients to have kind of wiggly arteries. These are looking at coronary arteries or seeing some aneurysm. And, this is clinically important. In the coronary arteries, this can lead to myocardial infarction, just like you can see in Kawasaki disease when you have an aneurysm. In the cerebral arteries, as I said, bleeds, the bronchial arteries, this can lead to massive pulmonary bleeds, which was, a more common cause of death until recently in these patients, along with infection. And then mesenteric arteries, we have seen large GI bleeds. So seeing these aneurysms really made us think more about the tissue remodeling in this disease. So just like when I was talking about that staph pneumonia, in that staph pneumonia, you could see, that there was some lung breakdown from the infection. And then when you have the lung breakdown from infection, the rest of us, if we had a staph pneumonia, would then kind of heal our lungs over time. But in these patients, their healing is abnormal. And what ends up happening is they're left with these large pneumatoceles. Sorry about that, will stop beeping. So they're left with these large pneumatoceles. And once they have those large pneumatoceles, then they're at risk for secondary infection with, aspergillus. Here's a patient with an aspergilloma inside the large pneumatoceal, or they have areas of bronchiectasis, and that can lead to chronic infection with gram-negatives like Pseudomonas or non-tuberculous mycobacteria. And this really causes them to have a lot of trouble, especially in the adult patients. It's really hard to treat these aspergillus infections, and then that can lead to local invasion and bleeding as well. The other time we also saw this was when the patients had surgeries. So here is a patient who went to his local hospital. He had this large infected pneumatoceal. That local hospital resected it, and they had a persistent bronchopleural fistula. So he had this air leak that went on and on and on for the next 9 months. It was like a total disaster. Here he is with his chest tube. And then, the infections that were here can then spread to the pleural space where they're even harder to treat. So, we had looked back at our patients that had lung surgery, and about half of them had actually had persistent bronchopleural fistula, and that often led to more surgery. So, we're really cautious about removing these in these patients, knowing that it can lead to further lung issues. So I collaborated with one of the vascular biologists down the hall from me, who's at National Heart Lung Blood Institute here at NIH, to look at the tissue remodeling. And, we knew that STAT3 was important for angiogenesis and extracellular remodeling, and this was clear in some of the experiments we did. So here on the left, we isolated fibroblasts from some of the Job syndrome patients, taking them from skin biopsies. And the first 3 bars here you can see are the controls, and the second 3 bars are the patients with dominant negative STAT3 mutations. And then they were stimulated with TNF alpha, and you can see that you're supposed to have this nice upregulation of matrix metalloproteinases that are involved in that extracellular tissue remodeling. But the Job syndrome patients with STAT3 mutations really did not have that upregulation. And this KDR is actually a VEGF receptor, like vascular endothelial growth factor receptor. We also took the fibroblasts, turned them into inducible pluripotent stem cells, and then made them into teratomas. And you can see here the one with the STAT3 mutation compared to the control. And you can see how small it is, and it doesn't have the normal vascular development. Again, showing a problem with angiogenesis. And then, this was actually corrected by putting in normal fibroblasts, not by putting in wild type endothelial cells. The only issue is that, now I feel like we've isolated some of the problem, but we're not sure what to do about this. So, having taken care of these patients now since 2005, and we followed since then, I've seen 160 patients now, with this disease. Things are really changing. We have many better antimicrobials. We're much better in terms of treating these patients' infections. So they're doing much better and living longer from an infectious disease standpoint. But as they're living longer, and you can see here them living longer, and before 2010, the median age of death in our cohort was 29. Now it's 44. And again, I have a patient now up to 71 years old. But as they're getting older, we're seeing so many orthopedic and vascular events. So we're seeing the aneurysms, we're seeing, this severe degenerative spine disease. You can see this patient's spine going the wrong direction. Patients are needing to get joints replaced. So I really think we're seeing kind of some of these issues related to disordered remodeling, which, you know, as I'm an infectious disease doctor, and I think you're all probably like immunologists and allergists or, you know, or infectious disease, you know, this isn't really what we're trained to do. So it's been increasingly hard for me taking care of these patients. And I feel like I need to get a little help, especially because at NIH, we don't have orthopedic surgeons. But yeah, the early diagnosis, though, has really affected them. I mean, you know, the patients now that are diagnosed at birth because of a family history, I just have such a different life. This child now, her dad was affected, so we diagnosed her right in the newborn period. And now she is 13 years old. She's never had a pneumonia. She's never had a boil. She's never been hospitalized. You know, it's really different when we do early interventions. So with her, we started chlorhexidine washes in the newborn period and then trimethoprim sulfur Bactrim when she was 2 months old. So just to kind of summarize some of the things about STAT3 deficient or dominant negative hyper IgE syndrome, I think about this disease when they have infection susceptibility like Candida staph, plus connective tissue abnormalities like the teeth issues or bones or joints and the destructive lung disease. But compared to some diseases with really high IgEs, there's less allergy than we expect. And then you diagnose this by sequencing STAT3. So which can either be done on its own or you can do it as part of a panel or whole exome sequencing, whatever is available where you are. So, and then in terms of my approach to care for these patients, it's still mostly supportive for most patients with suppressive antimicrobials. I typically use trimethoprim sulfa or Bactrim because that will prevent the staph infections. I consider antifungals. So for instance, if they're having a lot of trouble with Candida, I do put them on usually fluconazole. If the patients have aspergillus, I feel like it's never gonna in their lungs, then it never really goes away. And I usually then use, I typically use posaconazole. I'm not a fan of voriconazole usually because it can lead to photosensitivity and skin cancers long-term. As I mentioned before, if the patient's in a coccidioides or paracoccidioides area, I do give them prophylaxis with at least fluconazole to make sure they don't have invasive disease. I like using antiseptics like dilute bleach baths or chlorhexidine to control the eczema because it reduces Staph aureus colonization. You know, in recent years, I don't know in Latin America, but you know, it's gotten easier, although it's insanely expensive here. So, you know, if it's insanely expensive there, you might have trouble with this. But, you know, dupilumab, if their insurance will cover it, is the monoclonal, again, you know, that's helpful for eczema. And it's made a huge difference in some of my patients' lives, especially the adolescents and the kids that still have eczema. I consider IgG supplementation. These patients usually do have normal IgG levels, but they have poor specific antibodies. So if they're having infections despite prophylaxis and having, you know, and they have poor specific antibodies, I do usually start either IVIG or subcutaneous IgG. I keep an eye on their bone and dental health. You know, they have to make sure they go to the dentist to get the primary teeth out in time to have the secondary teeth come in properly. And then I do keep an eye on their bone as well. I look at vitamin D levels, for instance. And then just a lot of education to have a low suspicion for infection. So you pick up the pneumonias earlier. If the patients have bronchiectasis and pneumatoceles, and here is a patient with significant bronchiectasis who has chronic Pseudomonas infections, then we see lots of different types of infections, as I said, like Pseudomonas and molds and nontuberculous mycobacteria. And I always make sure I get sputum cultures so that if they have an exacerbation, I know what they're usually colonized with to treat. And I focus on airway clearance. So I'll often use hypertonic saline nebs with albuterol or airway clearance devices. I consider using azithromycin. I use that fairly frequently. If there's no non-tuberculous mycobacteria there, I always do cultures for that first. And I use long-term triazoles like posaconazole if mold is present. Sometimes I'll use other things that it's used in cystic fibrosis like tobramycin nebs for Pseudomonas. And then I think something that's become a much bigger question recently is, you know, what is the role of bone marrow transplantation in this disease? So, you know, back in 2000, there was this publication from the group in Newcastle in the UK that says bone marrow transplant doesn't correct hyper IgE syndrome. And there was another paper around this time where a patient died after transplantation. So that really kind of put a damper on things for a long time. But then in 2010, this paper came out saying that 2 patients with STAT3 mutations were transplanted and they both had lymphoma leading to this and did extraordinarily well. And they said everything got better. You know, their infections got better, their face changes got better, their bones got better. I mean, I don't know if that's all true, but I think after that point, people started thinking about transplant more for this disease. And around the world, I think there's been about 25 patients transplanted. And the UK group has now published, including that first individual, saying they think it helps. But, you know, as I said before, this is a multi-system disease, so it's only going to correct the hematopoietic cell issues. So we have transplanted 4 patients here. So 4 is not very many, kind of given our cohort. But again, we've also just transplanted children, but they've also all been at the worst end of the spectrum. These are the patients that, despite immune globulin replacement and prophylactic antimicrobials, you know, are still ending up in the hospital or having destructive lung disease. And, you know, all 4 of our patients have survived, and most of the patients around the world, as far as I know, have survived as well. And, you know, and they do see improvement in terms of the skin and the lungs. You do have to have good chimerisms. You know, this is a dominant negative mutation. So if you leave behind some of their own T cells, it will have negative effect for the good ones. So, you know, you need to make sure that it's a transplant with good chimerism. But, you know, I think one thing that none of us know in the field is, how do you predict in a little kid with Job syndrome how they're going to do? Because, you know, there's not a great genotype phenotype correlation here. There's not, you know, even with the same genetic defect, like the same change in STAT3, we can see very varying clinical manifestations. So we're trying to see if there's anything about these patients immunologically that will help us more looking at that. But anyways, you know, I think the more we understand transplant, we'll see, you know, what it actually corrects. So we think it will correct the infection phenotype. The bone phenotype, I don't know, maybe over time it will be corrected. It seems like all the NIH patients after their bone marrow transplants had more broken bones, but maybe over time it will be better. The vascular phenotype, I think it won't help. One of the patients in Britain actually had a coronary artery aneurysm 10 years after transplant, leading to a myocardial infarction. And then, you know, who knows what will happen if they have pneumonia after transplant, if they'll have healing issues. Okay, I'm going to switch from talking about Job syndrome to talking about DOCK8 deficiency. So DOCK8 deficiency was initially described as an autosomal recessive hyper IgE syndrome. Now it's considered kind of more appropriately a combined immune deficiency. This is a combined B and T cell defect that has progressive lymphopenia over time and worsened specific antibodies over time. You know, this disease also has eczema. It's much more IgE, like depending on their level of IgE, it can be really bad, or their IgEs can be low and they might not have any eczema at all. So I think it's much more variable. So, you know, we've had patients with normal IgEs and no eczema. And then, you know, I have a little boy here that I'm trying to get ready for transplant that has the worst eczema I think I've ever seen, you know, that you see with like bloody sheets and everything. These patients, though, are different from the Job syndrome patients in that they have a lot more viral infections. You can see the warts on this patient's fingers and the molluscum all over her neck. And there's a higher incidence of cancer. So DOCK8 is just expressed by the lymphocytes, which makes this disease much more pure immune deficiency and correctable by bone marrow transplant. It's involved in actin cell cytoskeleton, so it's really kind of how the cells move. And we think in part that's why they have so much trouble with the skin viral infections, because it's, you know, how the lymphocytes are moving in the skin to actually deal with the viral infections. And there they get all fragmented because they're not moving properly. The overall survival of this disease is much worse than Job syndrome. So, you know, in Job syndrome, my patients now at 71. Here, 50% of the patients in a multi-center study, including ours, have died by the age of 20 years old, and 3/4 of them have had a life-threatening infection. So when I first meet a patient with DOCK8 deficiency, I start talking to them about transplant and how we could get to transplant, because otherwise they develop lots of complications and it gets much more tricky. Here's just some of the complications that we've seen over time. You know, they can have a lot of trouble with bronchiectasis. They can have, you know, in addition to warts and molluscum, they can have a lot of trouble with herpes. This is this girl came to us as a teenager, and this is what her mouth looked like. She came from Turkey, and it was all kind of open sores. And it turned out it was all herpes. So we got that under control. Unfortunately, she eventually had to lose her teeth related to this. Cryptosporidium can cause liver disease like sclerosing cholangitis in this disease. And, you know, we see these dilated biliary ducts fairly frequently, and pretty much whenever we see that, we can find cryptosporidium by PCR. So in the, you know, in prior times, when we look for cryptosporidium by stains in the microbiology lab, like doing the direct fluorescent antibody stains or other stains for cryptosporidium, we did not see it. But when we look by PCR, we actually picked up cryptosporidia causing liver disease, and it can get pretty bad. So, just like you see in CD40 ligand deficiency, if you see, liver disease and cryptospordia, you want to transplant sooner rather than later. Here's a patient that actually developed cirrhosis with portal hypertension, who unfortunately they tried to do a liver transplant before a bone marrow transplant. She died of complications. Here is a patient with Burkitt's lymphoma. We see both EBV positive and EBV negative lymphoma in this, both Hodgkin's and non-Hodgkin's. This one had Burkitt's with a kidney primary that went actually to her CNS. You can also see funny vascular things here. This is more like a vasculitis. Sometimes we've seen it associated with zoster. Sometimes we don't find an etiology, but we think there's probably some virus that led to it. This is another, this is another patient actually from Turkey. The other one was from Lebanon. I just realized I said Turkey. This one was from Turkey. She has, she had presented with, she had all the usual complications, DACA deficiency, and then had a small stroke. And this is her MRA. You can see the left middle cerebral artery looks normal with all of its branches, and that's really lacking in the right middle cerebral artery here. And the basal artery was very stenotic. So she was transplanted now about 6-7 years ago, and this has stabilized and is actually beginning to look a little bit better over time. But it had progressively gotten worse for the couple of years leading up to transplant. Here's a 19-year-old. This patient had a calcified aorta that led to bilateral renal artery stenosis and then heart failure that we treated and then was successfully transplanted. And here's a patient with a large aortic aneurysm with a lot of atherosclerosis and calcification. So I would just make sure that you screen for these things in patients with DACA deficiency. Because for instance, if this is what your brain MRI looks like, you want the patient on some aspirin, except potentially during transplant. So we transplant these patients here. It's really remarkable when you see the warts going away. These are two siblings with really severe warts, and you can see, kind of nicely melted away. Here's a patient with molluscum, and here she is 6 months after transplant with the molluscum having gone away. Here's a patient with an EBV-driven lymphoma that was refractory to chemotherapy, her PET scan before and after transplant. It can be hard getting these patients ready for transplant. I have this kid right now with really severe eczema. We'll often do kind of wet wraps. You don't want to do like a ton of, you really want to avoid systemic steroids in this disease because of their issues with viruses. But, we do right before transplant, we'll wrap them with some topical steroids. So they're getting systemic steroids exposure, but to try to get a skin barrier so that then you can get them to transplant. And then I thought I would tell you about my most remarkable patient recently. This is like, I just had a poster about this patient. He said, it's just every once in a while you have an amazing case that actually survives. Anyways, this was a 21-year-old patient who lives in Dubai. He's a Palestinian refugee there. So, and he presented to see me after he was diagnosed with DACA deficiency to be evaluated for transplant. He had eczema since early childhood. He had recurrent ear and sinus and lung infections. He had warts and had those treated multiple times. He had really severe chickenpox when he was 4 years old. And then actually, the family thought he was reasonably okay, but then he had pneumocystis pneumonia at age 20 years. And that led to a genetic workup where he was actually found to have DACA deficiency. So he had a homozygous splice site variation. So then he came here, and this poor man, he was this young man and he thought he was fine. But we kept finding more and more things wrong. So when he first came to NIH, he had, you can see here the dilated biliary ducts. So, and he had in his stool cryptosporidium. So I think this was cryptosporidium related biliary disease. You can see he had this quite abnormal chest CT that actually grew Pseudomonas and Mycobacteria kansasii. So we treated that. But then, when I first met him, he was bright red and he had just been at the beach in Dubai and he thought it was just that, but he was very red and very itchy. And we did a skin biopsy and that actually showed cutaneous T-cell lymphoma, and there was involvement in his blood and his lymph nodes. So he was diagnosed with Sézary syndrome, so like a systemic cutaneous T-cell lymphoma. And then I did a brain MRI and I saw these white spots. We did a spinal tap and found JC virus. So he was actually diagnosed with PML. And we actually diagnosed that with brain biopsy as well because of the concern for Sézary syndrome. So we were in a really bad situation because we couldn't really treat his lymphoma with immune suppression because then his PML would get so severe. So what we did was amazingly, I convinced he had no neurologic symptoms despite having his PML. So I really wanted to kind of give him a chance to see if we could immune reconstitute him and get him through this. But, you know, PML is usually a fatal disease. So obviously a lot of people here thought I was kind of crazy. But we used bexarotene for his Sézary syndrome, which is a retinoid that kind of took the edge off of it. And then his brother was a full match, so it did not have DOCK8 deficiency. So we actually took some of the brother's T cells and grew them up against BK polyomavirus to use for treatment against the PML. We tried that, but his brain MRI just kept getting worse, and the JC viral load in his CSF kept getting worse. So we transplanted him, and we adjusted our regimen a little bit to get quicker T cell reconstitution. And he was fine neurologically until after transplant. So a few weeks after transplant, suddenly he had a lot of neurologic symptoms. Like he became aphasic, he was confused, he stopped being able to walk, he stopped being able to do anything basically. We repeated his spinal tap, and the JC virus had actually gone extremely down. That's the red line. And the white cells in his CSF had gone way up. So we diagnosed him with immune reconstitution syndrome from his PML, treated him with steroids. And then over the next few months, he got much, much, much better. And now I was so excited. I just saw him recently. He graduated from college. He's a year post-transplant. He's neurologically totally normal. His Sézary syndrome is in remission, and he looks wonderful. So that was one of my most exciting cases recently. But it was a little crazy of me to try that, but it worked out well. So anyways, DOCK8 deficiency, there's a really variable IgE in eczema and allergies, but it can be really, really severe. And the poor control, skin biome control, and a lot of the viruses, they'll have viremia. The malignancy is a really big deal, and you want to transplant them before that, ideally, the T-cell lymphopenia. So in the genetics, you can't just do whole exome sequencing. If you don't find anything there, you really need to look for mutations, because they can have, you need to look for deletions as well. Because you can see big deletions that can be missed on whole exome sequencing. Okay, now I thought I'd talk a little bit about IL-6ST. So IL-6 is that cytokine signals through. It has kind of a double receptor there with IL-6R and IL-6ST, which is the GP130 receptor, and then signals through STAT3. So over the last several years, there's been both heterozygous and homozygous loss of function mutations described in several patients. And I will tell you about my patient, but with that. So again, here is IL-6, goes through IL-6ST, IL-6R, and then you can see it's just upstream of STAT3. So this was my patient. This was a 9-year-old with cough for a few months, had some fever, cavitary lesions, and bronchiectasis, and his bronchoscopy was positive for aspergillus, and he was started on antifungals. And then when he was 10 years old, he had a spontaneous pneumothorax with persistent bronchopleural fistula. So it sounded kind of like Job syndrome there. But he had STAT3 and DOCK8 sequence, and they were normal. He was diagnosed with allergic bronchopulmonary aspergillosis, and he got some steroids. They tried emalizumab, like Xolair, without much help. Otherwise, he didn't have that many other findings. He had 8 primary teeth that were extracted, 1 minimal trauma fracture. We didn't really have eczema. He never had boils. He didn't have any trouble with candida. And, you know, his CT was remarkably, you know, destructive. And it was interesting that he really had trouble with aspergillus, but without having many other infections at all. So there is a scoring system for Jobs that, you know, we use sometimes. He had a little bit higher score there. So we had done whole exome sequencing on him, and we found this heterozygous frameshift mutation. Actually, we were really excited we found this, and then right then, I think it was right around a ESID meeting, and Vivian Beziet from Jean-Laurent Casanova's group was presenting a few patients that they found. So we included him in their publication. This is actually looking at the IL-6 signaling, and you can see here with kind of, you know, that there was like a dose dependent. So at kind of small amounts of IL-6, you can really see the difference in the IL-6 looking at phospho-STAT3 compared to kind of increased IL-6 amounts. So so we did see this variation. What's interesting for me about the patients with IL-6ST is that they really do seem to have a lot of trouble with aspergillus and really destructive lung disease and kind of ABPA. So we're trying to do some studies now to look into that some. So here I summarize some of the other diseases as well. So we talked a lot about Job syndrome with the dominant negative STAT3 mutations that have trouble with the mucocutaneous candidiasis, some eczema, the other infections, but and all the connective tissue issues. DOCK8 deficiency, that's more of a pure immune deficiency with the viral infections and the allergies. Oopsie. PGM3 deficiency, this is a glycosylation disorder. This disease can have a lot of neurologic defects. They usually have some sort of developmental delay and other issues. They can also have viral infections. They often have a high, they get more autoimmunity. And then there's dominant negative mutations in CARD11 that can have a fair amount of eczema and also some viral infections. Same with CARD14. This is more kind of severe allergies and eczema. ZNF341, which is binds our promoter and STAT3, so kind of mimics STAT3. I've never seen a patient with ZNF341 deficiency, so I don't have a great handle on it yet. The IL-6ST dominant negative that I just talked about, the one with biallelic is kind of what I just mentioned with the destructive lung disease, but more kind of skeletal and other issues. And then IL-6 receptor deficiency that there's only been a couple patients. So with that, I was going to finish up, and then let's see. Then I was told that we could do some cases. So I have some cases if we want to do that, or I can answer questions, or we can do a little bit of both. Okay, let's see. So we'll do the cases. Here it is. Okay, a 13-year-old with severe eczema starting around 2 months old, anaphylaxis of peanuts and sesame, recurrent ear infections with tubes, 3 hospitalizations for pneumonias, recurrent herpes infections, molluscum patches around her legs, arms, trunks, and eyelids, serum IgE 12,000. What's the most likely diagnosis? And some of these are multi-step, so this one won't be as hard at the beginning. So you can all vote on what you think is the most likely diagnosis. Oh, can you guys see what I do? I'll submit it. Then do we get to see the polls? Should I just move forward? Okay, maybe I'll just keep going. So I assume most of you guessed here, DOCK8 deficiency, that's the answer here. So I didn't talk that much about the lab findings here, but what lab finding do you think does not fit this diagnosis? So, oh, here we go, there is the poll. Okay, so that one was more likely with DOCK8 deficiency because it had all the viral infections, right, with the molluscum and, the much more significant allergies with the anaphylaxis. Great. Okay, I don't know how I did that. Oopsie. Okay, sorry, I'm not good with this part. Okay, so I didn't talk about this. So this is, we'll talk about this going through that. So that was most likely DOCK8 deficiency. Which lab finding doesn't fit? So all of these ones can go along. All these are true except for one. Low serum IgM, low serum IgG, mild lymphopenia, poor vaccine responses, and eosinophilia. And again, I didn't talk about this, so this is just, it gives me an opportunity to talk about it. And once we see the, now I know to wait for the polls, and then we'll go to the next slide. Do the do. Okay, everyone voted?
They're still voting, Doctor.
Oh, okay, thank you. Okay, so the correct answer, this one is actually low serum IgG. So all these other things actually fit. So you often do see a low serum IgM. This disease and Wiskott-Aldrich both have low serum IgM. So I didn't include that in my slides, so we could talk about it here. The IgG in this disease is usually normal. So that is the correct answer here. Mild lymphopenia, no one guessed, which is good because this is, they do have lymphopenia and it gets worse as they get older. And then a lot of the patients actually have poor vaccine responses. So a lot of these patients end up on immune globulin replacement therapy. And then a lot of the patients have eosinophilia. That was kind of a, because I did it as a negative type of question, so it was a little confusing. But the IgG is usually normal. It's low serum IgM, normal IgG. The IgA is variable, usually high IgE. There's usually some degree of lymphopenia, poor vaccine responses, and some degree of eosinophilia. Okay. So the liver tests are persistently elevated in this patient with DAC8 deficiency, but no other GI complaints. You worry about A, nodular regenerative hyperplasia of the liver, fatty liver, cholangitis from cryptosporidia, or liver abscesses. Okay, we'll wait for the CNN answers. Oopsie. Somehow I got to the wrong slide. Sorry. It's like if I touch anything on my computer, it gets messed up. Perfect. Oh, good. I taught you guys something there with that one. The last one I didn't do. So nodular regenerative the correct answer here is cryptosporidium. Nodular regenerative hyperplasia, I feel like we're seeing it in so many different immune deficiencies now. You see it in CVID, you see it in a lot of the PERDs, like, you can see it in STAT1 gain of function, you see it in STAT3 gain of function, you see it in even CGD, but you don't see it. I've never seen it in DAC8 deficiency. I don't know if it could happen, but I haven't seen it. Fatty liver, it's interesting. We're seeing a lot of fatty liver in Job syndrome, so I just threw that in there. And then liver abscesses, you don't usually see. So yeah, the correct answer is cryptosporidia. I usually then put the patients on nitazoxanide. I don't know if it really helps, but they clear it after transplant. Okay, case 2. A 10-year-old is admitted for streptococcus pneumonia, with empyema, develops a spontaneous pneumothorax with persistent bronchopleural fistula. Past history of recurrent thrush, ear infections, mild eczema, on exam, high palate, and double row of 4 teeth. Mostly diagnosis, PGM3 deficiency, that's the glycosylation disorder I mentioned, STAT3 dominant negative, that's Job syndrome, DAC8 deficiency, or TYK2 deficiency. Good, perfect. Yeah. So PGM3 deficiency, they don't have as much the healing issues. We didn't really talk about that though. But the persistent bronchopleural fistula, that sounds like dominant negative STAT3 or the IL-6ST. I was going to make one. Oh, sorry. I was going to make one comment here about TYK2. TYK2 deficiency was initially described as a hyper IgE syndrome, but most of the patients don't have that, and they have more viral infections of mycobacteria. Infections like that. So the answer here is STAT3 dominant negative. You think about that in this disease because of the thrush, the bad pneumonia with the pneumothorax with the persistent bronchopleural fistula, the ear infections, the high palate, the retained primary teeth. Okay, and then again, I want to talk so much about this, but which lab is not expected? So it's again a negative. So all of these are true, but one in the Job syndrome or STAT3 dominant negative patients. Very low Th17 cells, low memory B cells, low serum IgM, low memory T cells, or low naive T cells. So all those you can see. And I talked about this just a little bit. Whoops, I just realized I did this one wrong. I'm sorry, ignore E. Well, there's two correct answers here. Sorry, I have the low memory T and low naive. I think I started thinking about something else when I was doing this. So I messed up this one, but we'll go through it. But there's two possible answers. I need to correct it. Okay, so yeah, so the very low Th17 cells is true. So with dominant negative STAT3 PTHH and Job syndrome, they do have that. So that's not the answer. Low memory B cells is also true. So they usually have low memory B cells, low serum IgM. The IgM in this disease is usually normal. So that's DOCK8 deficiency. So that could be a correct answer. Low memory T cells, they usually do have low memory T cells, and low naive T cells is also, that's DOCK8 deficiency. So you could either answer low serum IgM or low naive T. Both of those things we don't see with Job syndrome. We do see in Job syndrome very low Th17 cells and low memory and B cells and low memory T cells. And with that, I just want to thank some of my, I work with a great group here at NIH and have different collaborators around here and around the country. And here is a mouse model that was actually developed at NIH that has a STAT3 variant. So I'm happy to answer any questions. Okay, here's a question. Why don't I, okay, thank you for the excellent presentation. Thank you. What age do you begin to perform imaging studies to look for aneurysms? How often after that in patients with dominant negative STAT3 and DOCK8? You know what I will do is I'm going to stop sharing just to make it a little easier to talk so I can see everything. So, we don't, so they're very different. So in Job syndrome, we see the cerebral artery aneurysm, the middle-sized arterial aneurysms, and we've only been systematically screening them in the brain and in the coronary arteries where we then can intervene. And we really haven't seen them in children. So we see them develop kind of every once in a while, late adolescence, maybe you see a teeny bit of dilation, but nothing really clinically important. So we do it by MRI. So we do it when we can have the child be in an MRI machine kind of calmly without sedation. So kind of, 8, 9, 10 years old, we start. But I don't think you really need to start screening in Job syndrome until they're adults, like young adults, late adolescents, early adults. DOCK8 deficiency, they don't get those same kind of middle-sized arterial aneurysm. They get usually either the aortic calcification and dilation, or we'll see the cerebral artery changes. So, and that can happen anytime. So when I first meet the patients, I do a brain MRI to look at the brain. And then I do like a chest, I'll scan them to look both for kind of bronchiectasis or lung issues, look at the aorta, and I'll look at kind of the liver and spleen. So, and I do that, when I first meet the patient, and then I try to get them to transplant. So I don't follow a lot of DOCK8 deficient patients over time, but I would think you could do that every couple of years otherwise. Oh no, and then the next one is in Spanish. So have you had anaphylaxis to medicines? I don't know. Someone else has got to translate that. My Spanish is only so good. But I can see it's something about anaphylaxis to medications in patients with DOCK8 deficiency. Oh, and the condition, I've never had one have I've had patients with anaphylaxis to plenty of medicines, but not to our conditioning agents. So we use busulfan and fludarabine and cyclophosphamide after transplant here, and we've never had anaphylaxis to that. So, but other medications, definitely. That would be a problem. Anything else?
Thank you very much, Dr.
Otherwise, no, it was really great to talk to you
this evening with you today.
Oh, thank you.
I have some questions.
Yeah, don't hesitate to reach out to me
in Spanish.
Oh, in Spanish? There's more?
¿En los pacientes trasplantados con deficiencia de DOCK8 han evidenciado anafilaxia durante el acondicionamiento?
No, I haven't had them had anaphylaxis during conditioning. We've had them to the conditioning medications. We've had them have anaphylaxis in the peri-transplant period, but not to the actual conditioning medications. But they do have anaphylaxis sometimes to medicines. Actually, when you do a bone marrow transplant and DOCK8 deficiency, you start their conditioning regimen for the bone marrow transplant, and it's really nice. You see like their eczema gets better, like a lot of things get better, but a lot of the anaphylaxis issues can last for years. I mean, they can have food allergy go on for years after transplant.
Muchas gracias. ¿Y en estos mismos pacientes se ha visto que desarrollaron algún tipo de enfermedad de injerto contra huésped?
The graft versus host disease, is that the question?
Yes.
Yes, we have seen graft versus host disease in the patients after transplant. Yeah, we initially we really did, and then we adjusted our transplant regimen. So now we use post-transplant Cytoxan after transplant to reduce the amount of graft versus host disease. And now we don't see it very much, but I don't think it's that different than any other disease. Like, but we have not, with our current transplant regimen, we haven't seen any chronic GVHD, and graft versus host disease that's of any significance has been really uncommon using post-transplant Cytoxan.
Muchas gracias. ¿Y cuál es su experiencia en los pacientes con STAT3 dominante negativo trasplantados en la edad adulta?
So, yeah, with DOCK8 deficiency or with STAT3?
With STAT3.
Oh, okay, so we've only transplanted, let's see, one young adult with STAT3. We have not transplanted that many adults. We've only transplanted, our group has only transplanted 4 patients with STAT3 dominant negative. The oldest was about 21 years old, and he did very well. He was having kind of recurrent pneumonias and skin issues and things like that. And he's done fine. He is about 1.5 years after transplant now and doing really well. Or maybe he's 2 years actually. But a lot of the older adults have a lot of worse lung disease that I don't think will get better and kind of have other complications for transplant. So we've kind of focused more on the younger individuals there. And then the oldest with DOCK8 deficiency was a 30-year-old. At your centers, do you do much transplant at some of the centers here? So probably not every single country does them, but I know in Mexico they do, and Argentina, Chile, Brazil.
No, en nuestro centro no tenemos experiencia de esos pacientes trasplantados.
En México, para STAT3, hasta ahorita, lo que yo conozco, no. Pero para DOCK8 sí hay una paciente trasplantada.
Okay, good. In terms of Latin America, I have one patient with STAT3 dominant negative from Guatemala that we plan to transplant this spring. I think in Guatemala, it's been hard for him to access some of the immune globulin replacement therapies and some other therapies. So we're going to transplant him here. And luckily he's learned some English because my Spanish keeps not being very good.
Muchas gracias, doctora. Acá tenemos otra pregunta del público, donde dice que el único donante para su paciente con DOCK8 es portador de psoriasis. ¿Tiene alguna recomendación sobre eso?
It's a good question. I think it probably depends kind of on the degree of psoriasis. If it was someone with really significant psoriatic arthritis, I think I would hesitate a little bit. We've done haplo identical donors too for DOCK8 deficiency using post-transplant cyclophosphamide. So I think if the patient has significant autoimmunity, I'd probably think about that. But it's if it's kind of just more mild psoriasis, I think I would go forward with transplant. And then here, in the absence of dupilumab, do you recommend the use of omalizumab? So I assume that's for the STAT3 patients. You know, usually their IgE is really high, and we really didn't see much happen. We did try omalizumab for some patients, but the IgE is so high that it barely like puts a drop in the bucket, you know? It's like you have to give them so many shots of omalizumab to make it worth it that we really haven't used it very much because of that.
Muchas gracias, doctora. Y en la ausencia, tenemos otra pregunta del público. En la ausencia de dupilumab, ¿recomienda el uso de omalizumab?
Yeah. Oh, okay. Should I answer again? I can answer again. Yeah, so that one, yeah, we have used omalizumab a few times in the patients with the STAT3 dominant negative mutations, but in general for the eczema, it really didn't make any difference. I think usually the IgE is really high, and you need a lot of then the omalizumab to bind to the IgE because it's a monoclonal against the IgE. So usually you just can't get enough, I don't think, omalizumab in there. So I haven't found it to be that helpful.
Muchas gracias, doctora. Edu, ¿vos querías hacer alguna otra pregunta?
Thank you very much. No. Muchas gracias por aceptar la invitación de Dani y mía y de todo el comité de la CIT, doctora. Espero que sea la primera de muchas ocasiones para que comparta con nosotros.
Well, thank you again for inviting me to speak today. I really appreciated it, and it was great to see some of you. So, okay, take care. Bye-bye.
Vamos a dar algunos anuncios.
Bueno, antes de despedirnos, los queremos invitar a todos a unirse al registro de la CIT, de nuestra sociedad, donde, bueno, entre otras cosas, se pueden recopilar datos clínicos de los pacientes con inmunodeficiencias, mejorar el diagnóstico, mejorar la clasificación de los pacientes, el pronóstico, optimizar los tratamientos, compilar datos de las inmunodeficiencias primarias y realizar estudios clínicos, genéticos y terapéuticos internacionales y multicéntricos. También los queremos invitar a los juniors a que se unan a nuestra sociedad, porque, bueno, entre otros beneficios, lo que van a poder hacer es participar del Summer School, que es una escuela de verano que se hace todos los años con los juniors, tener descuentos para el meeting bianual que realiza la CID, tener acceso a materiales didácticos de otras sociedades, como son ESID, CIS y, bueno, de nuestra propia sociedad, y acceder al registro de la CID. Y bueno, como no podemos dejar de invitarlos, para el próximo año, en octubre, el meeting de la Sociedad de la CID se va a realizar en Ciudad de México, así que quedan todos invitados. Estamos ansiosos, aunque falta todavía. Y bueno, para el próximo 22, los invitamos a los juniors a participar de la última cena del año. En este caso nos van a acompañar nuestros colegas colombianos, así que será un gusto tenerlos y esperamos contar con muchos de ustedes. Bueno, sin más que avisarles y agradecerles a todos por contar con la presencia, les dejamos un gran saludo y esperamos vernos pronto el 22. Un abrazo grande.